Okay, I know these are very short presentations, but actually they just initiate some thoughts. You can just think about them, and at this session that we have, at the end of a session, you can ask specific questions from our speakers. Our next speaker is a longtime colleague of ours at the Digestive Disease Institute, Dr. Sang Yang, who is part of the Department of Gastroenterology and Hepatology and Interventional Endoscopy. He will be presenting on the one of the subjects that you all are pretty familiar with it, and that's ERCP and issues with ERCP and perspective of ERCP in patients with PSC.
You all saw that, right? Okay. All right. Thank you very much. I'm honored to be here. Actually, I see a tremendous amount of zeal and camaraderie amongst you, and how exciting it is to see that currently an incurable disease, that you have a support for each other and belief that while the treatment is temporary, that there will be a cure in the future. And you all know that in Ohio, Northeast Ohio, this picture, we got only 3 weeks of window, so it was actually a tremendous amount of effort to actually come up with this picture itself. So the title of my talk today is the role of ERCP in the patients with PSC. So let me just do a quick survey, if you don't mind. How many of you yourself had ERCP or know a family member closely who had an ERCP? Great. And how many of you know what the acronym ERCP stands for? You guys are better than me when I was a medical student. Okay. So I was told that you all are very savvy when it comes to the details of the ERCP, and I hope I did not water down too much. But the objectives are as follows. So from the GI perspective, we'll talk about the technical aspects of ERCP. That gives a better understanding how complex this procedure actually can be. What are the indications? Because actually that's a moving target. It has changed, especially in the realms of the liver disease. So specifically, what's the role of ERCP in PSC? And more importantly, as you embark on a personal journey for yourself as well as your family members, as if they go through the ERCP, what are the questions that are helpful that you should ask the people who are performing the ERCP? Okay, so we all know that PSC, as you know, is a systemic disease. It's an autoimmune disease, and it affects the multiple facets of our body. And as far as the present day goes, there is no cure. Okay, then what about ERCP? So this is a tongue-tying acronym, Endoscopic Retrograde Cholangiopancreatography. So this is actually indeed a special endoscopic procedure. And I'll tell you why it is. So the scope itself, you can imagine that this scope is what we call a duodenoscope, has actually a camera on the side. So what you're navigating is not a front view, but you're looking at the side and driving it, basically. That's why it requires a special training. And the target itself is relatively small, so very small. It's a target is actually the bile duct or pancreatic duct, okay? And it is done to assess the bile duct or the pancreatic duct status. But it's technically challenging. So this is to show you. The left is the picture of regular upper scope. We call it gastroscope. The lens sits on the front, so you actually know where you're going. The picture on the right is the side viewing duodenoscope. Everything, including working channel and the camera, is on the side. So now you have to basically go through the muscle memories and what you're seeing in the visualization that is different than what you see in your eyes, and actually and get into the target. So here's a target. This is called the ampulla of Vader, and normally the size is about the half of your pinky nail. So you go there and your target is that small. So that's why it actually is routinely done by the gastroenterologist like myself, who actually undergoes another extra years of training. And it does have a diagnostic and therapeutic implications. Mostly these are done if the patients have symptoms and signs suggestive of biliary or pancreatic duct disease, and the manifestations being the jaundice or abnormalities, or most routine common indications outside of PSC, obviously, is a stone disease. Okay. So here are the simple steps, watered down as much as possible. So you identify, again, the ampulla of Vader. You access the little, in that ampulla, there's a little sliver of an opening called the orifice. And you actually get in there with a catheter called the cannulotome. And you take a look using the contrast, and then basically that gives you the anatomies of it. And finally, if the treatment is required, you treat it by making incisions, dilations, and extractions. And if needed, the stent. So once again, we go back to that size of the ampulla. It looks like almost like a small like a projections. Once you identify, the picture on the right that's the cannulotome. So somewhere in the middle, you identify the slit, and you actually get access to it. Take a nice picture of that. So the way I educate my medical students is the bile duct looks like a tree. You got a big trunk, big branch, small branch, so forth and so on. So picture on the if you're on the left, the big picture is the bile duct, and the small duct, the contrast that goes to the right across the spine is a pancreatic duct. Okay. And so when the picture on the right is what we call the cannulotome, and what we're doing there is we're making an incision using electrocautery. That's called the sphincterotomy, which is the beginning step of the treatment. All right. So in terms of the specifics of the ERCP and the PSC, we know that what we're looking for in terms of hallmark, this is one of the things that I had to memorize in medical school, is the B's on the string, which means multifocal annular stricture. It used to be the gold standard in terms of historic perspective, but largely it has been replaced by the MRCP, and many reasons, and rightfully so. And MRCP has come a long way. They're highly sensitive, and also they can be highly specific. And most importantly, it's non-invasive. So as long as you're not a claustrophobic, this actually should be a first choice. So this is a comparison of picture from the left and right. Left is MRCP, and right is in the ERCP. You can almost make out that this actually is almost identical or similar pictures, although the granularities on the MRCP does do a little bit of a less, allow us a closer inspections, if you will. Nevertheless, MRCP is a really good tool at this time. How good are they? So if you compare the MRCP with ERCP, we're talking about the sensitivities being almost identical. Sensitivities tells you that they are able to pick up something that's abnormal. Specificity, which means if they said there's something wrong, then there's something wrong. That is again almost identical between the MRCP and ERCP. However, there are certain circumstances where the ERCP might be slightly better, and those circumstances regarding liver disease are the early cirrhotics and early PSC patients. Okay, then ERCP is also fraught with the complications that we all heard and dread about. Okay, so pancreatitis, 3 to 5%. We as a physician, I have to admit, we tend to minimize that. Chances are it might be slightly higher than that. Okay, infection, another dreaded complication, which is cholangitis and sepsis. The bleeding actually does occur quite a bit, for us at least, especially the first time ERCP where we do the sphincterotomy. There's an arcuate artery that circles around, so there can be a bleeding that requires treatment. However, most of these complications are non-threatening, and they can be managed rather conservatively. Granted that the PSC, what we have done is that we are doing this in an autoimmune and compromised body, so the complication can be a little bit more severe in terms of their severity. So the role of ERCP in the days of the MRCP actually is that when MRCP doesn't give you really clear imaging or interpretations, or when there's an intervention that's contemplated, and when there's a question as to the dysplasia or progressive dysplasia, the dreaded word of C, which is the cholangiocarcinoma, is either suspected or contemplated. So this is that diagnostic approach that's routinely used. As we can see, the MRCP sits in the center of it. And when it's non-diagnostic, that's when we talk about the ERCP, or there's a therapeutic implication that's recommended. Okay, right there. So what are we talking about in terms of therapeutic implications? All right, so in the PSC patients, about half the patients will develop in their lifetime some signs of obstructions, okay, bile duct obstructions. And bile duct obstruction leads to the cessation of the bile flow, which you create this pool that doesn't go anywhere. What happens to that? There's an infection that's a cholangitis. Cholangitis can be life-threatening, and this needs to be decompressed. As one of my professors says, no amount of antibiotics in the world will cure the pus in your body. It has to be drained, and this is the most benign way of draining it. So hence, it can be life-saving. So here's the goal. So what we're looking for, if you have a diffuse disease in the so-called small branches of the liver, the ERCP doesn't serve you in terms of treatment implications. However, if you look at what we call a dominant stricture, so let's talk about this dominant stricture a little bit. So you see that little blink, I apologize. The dominant stricture is that big trunk, the trunk that connects the bile duct from the small bowel, the ampulla, to the intrahepatic subliver. So if you see a stricture there, then that's what you want to treat. And actually up to 50% of the patients PSC with the PSC does have this dominant stricture in their lifetime. It can be single or it can be multifocal. As long as this stricture sits in that common hepatic or common bile duct, yes, the treatment can be attempted. However, intrahepatic strictures are routinely treated with the ERCP. Okay. So again, the therapy involves several aspects of it. Sphincterotomy, the picture I showed you, making an incision, that's how we get in there and basically create an access that's easier. The stricture dilation, so you actually want to open up a little bit. There are two ways of doing it. Balloons, from the inside, you actually insert this catheter with the gun, you inject and gently dilate and you break off the stricture. Or you can use a rocket like a plastic catheter, so it's a graduated fashion of dilating. And finally, you want to put a stent in there. So it's this plastic tube that augments the bile drainage is what actually enhances the bile flow and diminishes the chances of the infections. These are obviously temporary. So anywhere between 8 to 12 weeks after the stent placement, this needs to be replaced. So this is the cartoon is on the left. That looks so ideal, but it is not. The picture, the fluoroscopic imaging on the right shows you that there's a stent. So there's a scope that's bright, and you can see that little tube right next to it. That's the plastic stent. So here we go. This is the cannulation is done. You can see that there is relative dilation just above the scope. So now next is balloon dilation. You can see that there's that graduated balloon goes up and dilating the stricture. Now, and then this is the part of the stent insertion. So this is the introduction cannula that introduces the stent. And finally, you can see that the stent is right below the scope and basically connecting between the communicating the dilated upstream to the ampulla. All right. So what do they do? If we do all these things, what are the gains that we have? It does improve in terms of the pruritus, and obviously it does reduce the risk of recurrent cholangitis, and it does help in terms of improving the liver function test. Now, the dominant strictures, this is associated, if you have a dominant strictures, the literatures have shown that it is associated with the reduced survival free of liver transplant. So treating this actually may buy you a time until the liver transplant actually. How about improved survival itself? So does it prolong your survival? Well, that's a controversial topic at this point, and the jury's still out there, I believe. Okay, what about the complications of ERCP specific to the PSC patients? In a nutshell, basically, in terms of complications of bleedings, ERC, pancreatitis, cholangitis, other than the cholangitis itself, but then again, you talk about the PSC, the other complications such as the pancreatitis, actually you're talking relatively similar. So in itself is not a significant red flag, if you will, of not undergoing the ERCP. If you need it, you need to get it. Most important thing, antibiotics a must. There are only two classes of patients that I give ERCP, the antibiotics a priori, no matter what. One is the PSC patient, and the other is liver transplant patient. So most of Bijan's patients, I give antibiotics. Okay, so this is where actually we progress to the next part of it, the disease progression, the dreaded word, there's this cholangiocarcinoma or concerns for cholangiocarcinoma, or what you guys hear, the confusing word cellular atypia. What does that mean? So when there is a suspicion of disease progression based on the ERCP and cholangiogram, that's where actually ERCP is more helpful than the MRCP, because what you can do is you can get in there and you can get the brush cytology. In fact, this is actually pictures of what we call a cholangioscopy or spyglass. You guys heard of that before? So basically, this is a small, really small scope that has a camera in it, and this camera is able to go inside a bile duct and take a picture of it and get a biopsy of it. So the picture on the right, the B, is actually what it looks like in terms of normal fibrotic strictures. Picture on the A kind of concerns you. It looks a little different, right? It looks red, swollen, irregular. This is where we are concerned about development of cholangiocarcinoma, if you will. Not only now we can just do the brush cytology with this scope, we can actually get in there and get a direct biopsy, if you will. Okay, so the suspicious strictures, we do routine things, the liver function test, the tumor markers, routine imagings, the ERC, and when we talk about that, when you compare that with the ERCPs and its available amenities, the brush cytology traditionally has not been all that great. And now along comes this fluorescent method, which was developed in Mayo, which actually has increased the sensitivity and specificity, but still to be much desired. However, if you talk about the the augmentation of that cholangioscopy, it does actually increase the sensitivity and specificity tremendously. Again, in itself is additional training from the additional training that I have gotten. So actually, if you want something like this to be done, you really would like to go to two places where there's a physician who has done extra training, more importantly, where you have a liver transplant surgeon like Bijay. So let me conclude my talk today. So ERCP is, again, technically very challenging endoscopic test to assess the status of the bile duct. Again, we accept the fact that it has largely replaced by the MRCP as an initial imaging of choice. The specific role of ERCP still remains in terms of ambiguous diagnosis by the MRCP if the therapeutic implication is strong, and if there is any question of early detection of disease progression to cholangiocarcinoma or cellular atypia. Thank you very much for your attention. Oh, I forgot this. I'll leave you with this. I got it now.